Good evening, friends. This is Dr. Rajkumar from Baroda. IPS Vadodara branch is bringing up this online CME, the sole intention of it being to upskill the psychiatrists and see that they are in a better position to manage their clients. To throw more light on it, I invite Dr. Bhaskar Mukherjee. Bhaskar, the platform is yours.
Hello everyone. Today, as it is the inaugural session of this program, I would like to take some minutes to make you understand what we are trying to do, what is our objective, how we are going about it, and what we are hoping to achieve through it. And we should go on for around 30 minutes, and after 30 minutes, we would talk about the all pervasive stress of psychiatry for 30 minutes more. Now, what we are trying to do, what is happening in psychiatry is a very curious thing. No other medical branch actually is still not sure that what organ they treat. Every cardiologist know that they are treating the heart. Every neurologist know they are treating the peripheral nervous system and vascular system of brain and spinal cord. Every endocrinologists know that they are dealing with endocrine system of body. But till today, no two psychiatrists are really on a same page when they are asked what they treat. Some called brain, some called mind, some doesn't even know what they should talk. And this has created a enormous variability in psychiatric practice all over the world. Standing there, it is solely needed to bring psychiatrists in a common page, common platform where they know that we treat brain, we treat nothing but the brain only. And along with brain being the master organ, we also treat rest of the body organs in an auxiliary fashion. I mean, in rest of the body organs and rest of the medical specialties, a psychiatry can a psychiatrist can give his or her opinion as a secondary consultant, or if you would like to feel proud of yourself, then super consultant. Now, if we want to achieve that, we have to teach psychiatrists the biomedical basis of what they are doing, not psychological basis, not any other basis. So, for teaching psychiatrists the biomedical basis, we need to talk about brain. We need to talk about brain function in everyday life, brain function in normal uh, side of humanity, and brain function in different abnormal situation and abnormal expressions of brain. Some of those who are some of these abnormal expressions are actually termed as psychiatric symptom or psychiatric disorder. Some of them are neurological symptom or neurological disorder, but ultimately all originate from brain's complex neural interaction and brain's complex neural and immune interaction. So we need to teach psychiatrists these basics. The third one is more elusive objective. We would like everyone who is going to listen to this series think and think more about what they are doing, how they are doing, and does it justify the scientific logic and parameters? Does it justify to say that there is neurotransmitter dysfunction in brain, which is actually not? Does it justify to say there are antipsychotic, there are antidepressant, there are anti-epileptic, and so on, while all these drugs are actually systematically acting drug whose one area of function is all over the brain and other areas of function are throughout the body, and they neither treat psychosis, neither treat depression, neither treat epilepsy. They treat the brain. So we should not limit them into our imaginary names. Similarly, we would try to teach psychiatrists other critical thinking, like if a certain group of drug is not working, then what are our choices? Is there any treatment resistance in psychiatry, or it is just a handed down legacy of those era in psychiatry where a patient in couch used to be analyzed, and those who resist those uh, analysis and other things, they are termed as therapy resistant? We would talk about that. And lastly, we would like all psychiatrists to have basic understanding of whole body, because psychiatry in its actual form would be more inclusive of every medical branch, because brain is part of every organ function. Immune dysfunction has a huge brain component in it. Any immune dysfunction, any endocrine dysfunction has a huge brain component in it. Any cardiac dysfunction has a huge brain component in it. Similarly, gastrointestinal dysfunction, similarly, various kidney disease, similarly, all other systematic disease, they have a huge gap in their treatment. The gap which is occupied by brain, and the gap which should be filled by physicians of brain. That means we. So these are our objectives, and we would try to fulfill these objectives. Now, how we are planning to go about it? We have made this series for the people who are just entering psychiatry, means first year PGT, to those people who have passed MD but still thinks themselves as student. And needless to say, the speakers would be also juniors, means those who have passed MD in less than a year to maximum 10. Maximum it would be 10 years after MD. Does that mean there won't be any senior? Yes, there would be. But they would be far and in between. Most of the speakers would be from recent PG pass outs and recent group of people. We would train them, and we would teach them what to speak about, but ultimately it is their job to express what they are being guided, how they are being guided, and ultimately to do justice to the topic given to you. Any junior who wants to speak in this program can contact me or Dr. Rajkumar or Dr. Malay Dakre. Any one of us, if you connect, we would be happy to help you for being a speaker, and we would be happy to give you a platform where all of you can train yourself to be the speakers. We just want competence from your side, dedication from your side, and scientific understanding from your side. Rest of the things we would be able to help you with so that you can speak on the topics we decide for you. Then comes when we are going to do these talks. As the name implies, it is Brain on Wednesday. So we would talk about brain on Wednesdays, but not every Wednesday. That would be too much pressure because every day of week is occupied by one webinar or other, and many a times 3 to 4 webinars are there in a weekday, and I don't even want to speculate how many webinars in a day are there in weekends, probably 9 to 10 or more. So we don't want to bother everyone by keeping it every week. So it would be a bi-monthly affair. 2 weeks in a month, we would convene and we would talk about various basic science topic and which would be translated, various current clinical topic which would be talked from brain point of view and which would be given due clinical importance from a brain point of view, as well as various conundrums and debate we face in psychiatry. For example, drugs in pregnancy and lactation should be given, should not be given. We would be arranging few debates on it. Perinatal psychiatry, a branch almost engulfed by psychology. We would be doing various seminars and various sessions on prenatal psychiatry. Similarly, we would toy with some new ideas like infant treatment. Should we do it? Should we not do it? Because we are seeing that trajectory of development of psychiatric symptoms start from womb. So are we going to treat it in the womb or in early infancy? Considering the ethical implication, the moral implication, and other things, we would touch on these topics. And ultimately, it would be the listener and their input which would guide us to choose topic after topic. After each seminar, we are going to talk about some key points and we would like you to give your feedback on these key points in your response to us. We are expecting some feedback from you. We are expecting some constructive criticism and not so constructive criticisms from you. And we are expecting you to give your free and frank opinion. This would be a directed series. This would be a brain centric series, but we would try to keep it as democratic as is possible. So, with this introduction, I hope you are now mostly clear about what to expect and what not to expect from it. Don't expect us talking about tender loving cares, but we might talk about various brain changes with psychotherapy, various brain changes with various placebos, and we might shed lights on how various non-pharmacological means work. That is something within our purview. But we are not going to discuss about how to manage psychologically a patient, how to talk about psychobabble, or how to talk about various other things. And with the lengthy introduction is over, let's go to stress of psychiatry. This is for you, my dear PGTs, if any of you are here. From your first day of first year, you have been trained to record stressor. But what is stressor? Let me give you an example of myself. You would be able to understand it more clearly. I am a person who is more emotionally detached than most person, who doesn't have much understanding of how human beings talk, how human beings think, and how human beings talk about in various things in layered manner. Means think something, talk something, and ultimately do something. That is beyond my understanding. So, if you want to exhibit stressor in me and you want to go like childhood, adverse environment, and things like that, that won't be of much importance to me. But in traditional teaching, you are asked to elicit these stresses. Similarly, if you ask me or someone like me about their bereavements or about their various setbacks in life, they won't have much problems with that. They would be actually discounting most of these emotional reactions. But according to your teaching and according to what what has been told to you, every adverse event happening in a person's life is a stressor. But you can see the kind of person I am. For me, they don't matter. So what would be the thing that would matter for me? Things that go against my principles, things that I expected to happen differently, but happened not to my expectation, and things like that. But for that, you need to know me. You need to know how my brain works, and then you think about stressors and other things. But unfortunately, nobody teaches you to assess the brain of the patient or the person sitting in front. They teach you stressor. Then there is another point. If you think, you would find out that every person's response to this so-called stressor is different. When your near and close one, let's say, imagine a situation where your mother has died. For you, depending on your brain, what would be the reaction? Some of you would show no reaction, would just digest the bereavement and would go on with your life. Some of you would be debilitated for few months. Some of you would be debilitated for a few years. And for some of you, it is just a passing affair. What decides these different reactions? Your brain attachment to the brain of your mother, prevalent conditions of your mother, whether you are expecting it or not, and other thing. So that is, does it really matter to say your mother's death is a stressor for you? It would be only a stressor if your brain is vulnerable. Otherwise, it is not. If I replace mother with your pet, other one, the same thing would remain. Every negative event happening to your life would matter or not matter based on your brain state. And if someone is sufficiently vulnerable, no stressor is required. So this brainwashing of yours to think in the name of stressors has to go. And the only one who can do it are the students who has to ask why this stressor is important to themselves. Don't fight with your teachers. Don't fight with anyone because every brain is biased. No brain has the power to be just dispassionate and just unbiased because that is a utopian concept. Human brain is triggered to give importance, one experience more valence than other. Human brain is actually wired to give one viewpoint more importance than other. So our judgment system, our thinking system is always flawed and always non-utopian. We judge, we do faults, we are biased. So if someone is telling you to elicit stressor in everything, that just means that person is biased towards that thing. And fighting with that person would not solve anything except guaranteeing your torment in next few months or few years of PGC. So don't fight with the one who is telling you to elicit trauma. Rather, question yourself, is trauma important or not? Is stressor important or not? If it is important, then in whom? Another thing that comes here is childhood adverse experience. You would say childhood adverse experience is a severe stressor we all know about. Is it? Think. Childhood adverse experience is part of every child's growth. Every child goes to some adverse effect or some other thing. depending on their liking, their disliking, and their brain's wiring, their brain's nature. So maybe not giving a toy to an infant is a huge stressor for that infant and huge traumatic event for that infant depending on his or her brain's configuration. Maybe giving or abusing someone sexually had similar result in some other brain depending on their vulnerability. For some other brain, sexual abuse in childhood is normalified and they don't have any negative or positive feeling about it. So you see, even childhood adverse reaction, the one which you have been told to be universally as a stressor, doesn't really qualify as a stressor. Then you would ask me, why then there is methylome change in childhood adverse reaction person's brain? Methylome change means nothing. The methylation profile of DNA. Sadly, those paper which reports that there is hypermethylation in brain in those who have faced childhood adverse experience, those paper has forgotten to tell whether there is development of more methylation after experience or not. Those papers never really specified how much adverse event is reaction. Those papers have never specified if the finding is universal across all the genders and races. They haven't because it is not possible. They cannot do it and they cannot predict it. But the publish or paris of today's academic world makes everyone publish anything. They don't bother about substantiation of this claim because substantiate or suffocate a claim that used to be prevalent in academia of 1960s or 70s has gone to drain. Nobody wants to substantiate anything. They just need to publish it, and based on publication bias, that is, which is hot topic now, they are think would publish, increasing the so-called evidence base of something and creating high evidence base for childhood adverse experience because that is in thing now. That topic where chance of publication is very high. There is no way to say childhood adverse experience does anything or nothing or something. But we want to pose all knowing rather than saying that we have no way to know it. We don't have any way to confirm whether something in outside has caused some change in the brain because we don't have live brain activity measures. Then you'd again ask why you are saying so. fMRI, FDG PET, all are there. Are they there? In past, there were frequent errors in fMRI software to detect whether there is brain activity or not. For those of you who are interested, they can see a dead fish error of fMRI. You would find some interesting thing. Similarly, there are various software errors which can make a lot of fMRI findings obsolete. And according to very critical analysis, any paper published on fMRI before 2016 or 17 should be deemed as useless, because by that time we could understand a lot of errors in fMRI softwares. And after that, we are able to correct it. But till then, a lot of paper has been published on fMRI of brain and various things, and they amount to almost nothing. They amount to saying this makes this happen because I say so. And all of the psychiatry is because I say so. Eminence-based medicine given rise to consensus-based statement and consensus-based guideline. But they are considered evidence basis for psychiatry. We practice the form, but we have not really reached anywhere near impassionate, unbiased evidence based in psychiatry. We have data of very few people, a few thousand actually, not even tens of thousand data. It is less like we maximum data we have is around 20,000, and we apply that data to create various guidelines for more than 8 billion people. That's the irony of psychiatry. Anyway, now there is another interesting thing in this trauma and stress and finding of stressor. Let's say a environmental thing happened. This is the environmental thing. Now, this body of mine is just the internal environment. So something has happened in external environment, and it has actually touched the interface between external environment and internal environment. Now, that touching of the barrier can happen different ways. It can be this, it can be this, it can be this, and depending on the impact, ultimately a group of biological signals would generate from the interface. But the biological signal would be same if I touch this, if I touch this, if I touch this, or if I touch this. Just the intensity would vary. But all the biological signals that would be generated by external environment would be the same. Then those biological reaction that has happened in external and internal environment interface would go down further into the various cell. But before entering the cell, they would again impact the cell wall, and the cell wall impact would again be transmitted to internal environment of cell, there a further dampening would happen. So ultimately, when the epigenetic change or any change that would happen in cells and that would come up as reaction, there won't be any way for cell to tell whether the change is due to someone slapped me or I have been facing poverty for some time or I am malnourished or I have suffered from fever or I have suffered from some serious setback in life or simply some dysfunction of the barrier which transmitted normally. You can see again this stress concept has no validity if each barrier dampens the external stimuli and each barrier changes the external stimuli into another form of biological networking. It is not possible to delineate what has brought about a particular change in brain or brain cell or any other cellular DNA just because something has happened in the external environment. This is the biggest problem of all the stress and stressor theory because there is no specificity for any so-called stressor. They are all similar. So standing there, if stressor doesn't matter, how we should go about taking history and thinking history. This brings us to a very interesting area. What is the interesting area? It is the lifelong trajectory of development. If you consider the patient and your interaction as just a cross-sectional event, then the patient has gone to a variety of trajectories to come to that transaction or that that window of time, whatever you say. When the patient is interacting with you, that can be a transactional thing in your conception or can be a window of time in your conception. But for to reach there, patient has gone through a long development. And if you start tracing that development from birth or ideally from the conception of mother, then you would start finding the trajectories. And those trajectories would define what would actually be stressful for a person and what would not be. The trajectory development starts with conception of mother, then mother's pregnancy behavioral expression as well as various symptomatic expression, then pregnancy complication of mother, then pregnancy complication of baby, then comes into specific birth of the baby, the mode of delivery, immediate APGAR score, immediate cry and other thing, then APGAR score after 24 hours, APGAR score or neurodevelopmental screening after 2 to 3 days to up to 10 days. Along with that, we have to formulate whether there is any immediate postpartum jaundice or hypercoagulability or bleeding tendency or something. Then comes the early infantile phase, first 6 months, how the baby is behaving, how the how the baby was behaving, how the baby was feeding, how the baby was interacting. Then comes the next 6 months, how the baby was developing, how the baby was interacting, feeding behavior, other behavior, and it would go on till the point you are examining and talking with the patient. And you would start finding that various junctional event has happened. Some changes has happened during first going to school. Some changes has happened during first 6 months. Some changes has happened during next 6 months. Some changes has happened during early toddler phase. Some changes has happened during early school, then late school. Some changes has happened during puberty. Puberty means onset of puberty. Then some changes has happened during mid puberty and late adolescence. Then some changes have happened early adult age or early young adult age. And you would start noting the different changed trajectories that a human being represent. And you would start finding out how those things ultimately translate into various brain trait, brain state, and psychiatric symptoms. This would give us more idea about various future treatment strategies, various treatment choices, and other things. And probably this would modernize the all pervasive trauma, all pervasive stress, and all pervasive stressor of psychiatry. Those psychological concepts are neither logical nor scientific. And it is time we start dissecting them from a scientific point of view. And that would be our first baby step towards understanding brain and psychiatry. We have 15 minutes left, and I am summing up this talk, which I've been giving extempore for last 30 minutes. The home task for the students would be to critically ask themselves, are stressor matters? Do asking for trauma really impact a person's treatment? If we start discarding stressor, if we start discarding all these trauma, stressor, and stress, how that impact our treatment decision, our treatment choices, and other things. And also to self introspect that would you like to refine these things and how would you like to refine it? If you want to know more about stress, I would like you to read something about number one, cardiac brain or intrinsic cardiac nervous system, intrinsic enteric nervous system, intrinsic pulmonary nervous system, intrinsic renal nervous system, and other things. Those which are multiple brains of our body and their interaction with central nervous system. I would also like you to read more about immune system and how immune system changes affect different brain state. And thirdly, I would also like you to read about the interaction between central, that is brain, and peripheral immune system. With this, I am closing up my presentation. Now, let's see if you have any questions or not.
A request to all the participants, kindly put your questions in the chat box so that we can answer them as soon as possible. Yes, Bhaskar, there is a question. Isn't transactional analysis a very good means in finding out the contaminated ego state and accordingly treat the stressor? This is by Dr. Rajiv Pandarthil.
As I was talking about stressor, I said that stressors doesn't matter. So standing there, you can try to find out the so-called stressor from every means, but that would not affect the treatment choices. Rather, if you start finding out how that particular patient's brain react, how that particular patient's brain has gone through every developmental stage, how the person's developmental trajectory have been, then that would have a more profound impact on treatment, that would have a more profound impact on your understanding of the patient and prognosis of the patient.
Yeah. Any more questions? Kindly type them.
Yes.
In the meantime, can I just ask Dr. Malain to chip in, as he is also one of the mentors in the background?
Yeah. Thank you, Dr. Rajkumar. Thanks, Bhaskar, for a nice talk. I would not add anything to the topic as such, but I'll just give you a background of things as kind of we understand them, that we need to focus on how things work, how things happen, rather than just symptoms. So some of the things when we discuss may seem quite counterintuitive, but unless we make an effort to understand the things. Now Bhaskar mentioned a lot about how the individual stressor doesn't the stressor doesn't, what is it is less important than how it affects the individual, what are the changes that happen, and where we can kind of intervene. So those things are important, and we would like to focus on that. We have been focusing always on the symptoms, but symptoms are like fever and cough. I mean, there's no one reason for fever, there's no one reason for cough. And similarly, the end result of something is the fever, but what is the process, what is the chain of events that led to it might be different for different etiologies, whether it's an infection or whether it is something else. So this is an attempt, this series of talks is an attempt to understand things better, and improve the way we look at symptoms, improve the way we kind of intervene. So in the meanwhile, not taking much time, there are a few more questions that have come up. So I'll put the questions to Dr. Bhaskar. This question is from Dr. Archana Kantak. please give more information about epigenetic changes. You did mention about that I
Methyl
missed.
dopamine.
Yeah, I missed a bit because I had some issues logging in with this thing. So yes, so for her sake and for my sake also, would you like to repeat and add some things to that?
Actually, epigenetic changes in psychiatry, their misuse, their use is actually going to be a few lecture in this series. So I would not go into details now. Later, we would come back to talk about different epigenetic changes, different epigenetic changes that are misused by psychiatry, that different abuse of epigenetics as well as different real epigenetics. But for now, I would just give you some understanding. Imagine that all your DNA is actually not your genes. Total gene is just 1.5% of full DNA. So if that 1.5% control the 20,000 genes of our body, then what the rest of the DNA does? This is what is known as junk DNA, or so-called, at this moment we are talking about epigenome. The epigenetic control part of DNA. Now, how it works? In presence of various conditions and various things, various genes' ability to transcribe various protein is either enhanced or suppressed by this non-coding part. Sometimes, due to their own mutation, a few genes become more susceptible to environment. Sometimes, due to their mutation, a few genes become less susceptible to environmental change, and that is how various gene function is regulated by non-coding part of DNA, and environment plays a part in activating those mechanisms. Methylation in generally silences a gene. That doesn't mean methylation is bad. For example, if you silence a rapid proliferation of cell enhancing gene, you are actually giving the animal some protection against cancer. So acetylation increases function of a gene. Acetylation of histone protein makes the DNA open up and a gene is more exposed to transcription. Not all acetylation are good. Sometimes some genes are to be kept in check, and acetylating histone of those genes exposes them and create problems. So epigenetics is actually a very complex topic. We would come back to it, but not today. The second question that was unanswered is Ritik's question. If we don't know the developmental trajectory, then how we can guess in a old person? In old person, we don't need to know developmental trajectory as much as a child. If we get it, then it is very good. But if we don't get it, we can at least ask for the lifelong history from the relatives who are present. And if no relative is present, there is a shortcut way. But I would rather talk about those shortcut ways once people understand brain more rather than in this fast episode.
Okay.
I don't want them confused.
Okay. Thanks, Bhaskar. Okay, just there is one comment. Thank you for a great presentation. Is it possible to have a video recording for future review? I think, sir,
Yeah.
we will
It
be
is-
having. So
It is there.
yeah.
All
So
the recordings will be
yes.
uploaded on the YouTube and the links will be given to you people.
So I think Dr. Sunday John would be happy with that because that was what was asked by Dr. John. Okay, now Dr. Sanjay Barot says, as conditions in Gaza are extremely stressful, what would be the reaction in the populace at large? You want to
Those,
venture into that?
yes, just 2 lines.
Hmm.
Number one, as there is an epidemic of complex PTSD going on all around the Western world, we would be seeing huge number of overdiagnosis of complex PTSD in Gaza. And if UK sends a team along with USA, almost all living person in Gaza after this war, if any are living, they would be stamped as complex PTSD. In real life, there would be trauma of losing livelihood, there would be trauma of losing a lot of things, but most would be able to move on, except those with inherent genetic vulnerabilities in immune system, neural development, as well as in endocrine system. And in those, these Gaza bombing and Gaza genocide would create some psychiatric symptoms.
Okay.
Sargar Bhalke wants to find if there is a measuring severity of stressors instead of determining mode or quality of stressors help in the treatment choices.
Dr. Sagar Bhalke, we have no way to measure severity of stressor. Let's say I someone slaps me in front of a large number of people. If I am someone who doesn't bother about society, then that slap would not affect me. And if I am someone who is mortified by public opinion, then that slap would ruin my life in my self-image. So how would you measure the severity? That is number one. It depends on a particular brain. Number two, how would you measure severity even if all the events were same for everyone? Because for that you need to have real brain monitoring system. We don't have it. So there is no way of measuring severity of stress. And standing in that area, I'm saying stresses doesn't really matter.
Okay.
Hmm.
So where is that? So asking for stressors and trauma and how the person coped up with that can give the psychiatrist an idea about how resilient the brain of a person is. So any
Yeah,
comments on that?
comment by Vishal.
Yeah.
There are multiple Vishal. I don't know who are you.
Hmm.
So the thing is, asking for various life event and how the person coped up with the life event would give up some idea about long-term trajectory of a brain. That is a good opinion. But focusing on a particular event would not give us much. So yes, asking the lifelong reaction, asking the lifelong trait would always have a value. How much that we don't know.
Okay. So there are two questions asked by Dr. Ashwin Mohan. The first one is that stress is a common pathway, but for the person, the context matters. And that is the argument put forward by therapists. And of course, the person needs some resolution. So what's your opinion on that? That's the first one. You can answer that, or you can counter comment on that.
Stress doesn't have a common pathway. Stress, uh, and stress has multiple and varied pathway. That is number one. So context actually matter.
Context as in?
context, as in, let's say, context means gene environment interaction or animal environment interaction. The animal, have certain vulnerabilities and certain resilience to certain events and certain mishaps. If the mishap, the nature of mishap and the vulnerability of the animal matches, then the context matters, otherwise it not. So standing there without knowing my particular vulnerability and without knowing the particular type of things that would come bring out the vulnerability, this stressor and other thing has no value. I don't understand how the it is mechanical argument, so that someone else has to give me idea, because this is actually the what is happening scientifically. How does that become mechanical? That I don't know.
Okay. And it's of course, this the second one is a comment that the biggest problem in using the English language for describing, I mean, the biggest problem is that we are using the English language for describing a biological phenomenon, and a phenomenon that has a usual meaning in common parlance. So basically what he's trying to say is that what is the common usage or the common meaning for a word is what we try and ascribe to something uh, that we are considering scientific. So there is going to be a confusion, and
There has to be a confusion.
yeah, so there will be a confusion, and therefore we need a different terminology when we are so I mean that's the first thing. Stress, I mean, the understanding, the biological understanding of stress is something completely different from what people talk about when they say that I have got stress or I am stressed or something like that. Yeah. So do we have any more questions?
I think they are.
The thing is, I would like to have something here. The thing is, you have to understand all psychiatric nomenclature, except psychosis, major psychosis, and bipolar, have come from a group of people who did a decade-long meetings from 1970 to 1980 and gave scientific name to common language terms. So it was only of a decade that actually made psychiatry having this kind of hiccup. So either we correct that folly of a decade, or we create new name, because there is no meaning of depression. There is a common person language, and that has been given a medical name. There is no name of anxiety, because anxiety is just a common person description of something that we have taken and made a medical diagnosis. Similarly, everything that we talk about is common person language taken and given a medical meaning. So that has to change.
Okay,
Can we monitor inflammatory markers as a crude proxy to stress? Asked by Dr. Nachiket.
Very crude, and I would rather say very non-specific, because inflammatory marker can rise due to a lot of things. Whether that is due to a particular event happening to a person or due to something else, we would never know.
Dr. Nidhi asks, can you broadly guide us about the pharmacological treatment measures for stress based on various clinical presentations of stress or symptoms encountered because of stress?
If we talk about stress in biological form, means a functional demand placed on a brain that is vulnerable and not being met up by the deficit brain, then this biological definition of stress is behind every psychiatric symptom, starting from acute psychosis to chronic psychosis to bipolar to the current depression, to the obsessive compulsive symptom, to anything. So if I broadly guide that, I need to write a verbal textbook of psychiatry at this moment. That is not possible. But with each episode, we would give the various pharmacological treatment on it, because brain on Wednesday is also psychopharmacology translated into neuropharmacology.
Dr. Dakshinamurthy asks, do you mean psychiatric disorders are due to gene level defects and that will sure express at many stages of life from birth till death, which we need to create more awareness among doctors as well as public? Apart from disorders, what about some deviations or so-called traits? Does they need to be treated, or any empirical treatment is there that can be given prophylactically for present betterment as well as to prevent future disorder that are prone for? If so, then what?
Very good question. Very good question. If there was question, an award for best question, this would have been the question. Anyway, yes, psychiatric disorders are due to gene level defects, and that would manifest from birth to death at various levels. The first vulnerability part is start of adolescence to peak adolescence to end of adolescence, means 15 to 25. It is common for male and female. The second, and it is adolescence because here many gene functions change. Then second vulnerability period, common to both male and female, is midlife, 40 to 45 starting point, and end point is around 60 to 65. Here also the various gene changes happen, and this is another common point of expression by all the genetic diseases, not only psychiatric diseases. Then comes female specific vulnerability. Number one, menarche. Number two, pregnancy. Number three, menopause. And these are the times when these gene level defects manifest. Sometimes they manifest as pure brain level defect and we get psychiatric symptom or neurological symptom. Sometimes they manifest as brain and body level disorder, both various autoimmune diseases which are systemic or along with brain related. Sometimes they happen in mostly body followed by brain. Hypertension, diabetes, cardiac disease, and other things. So yes, these are gene level diseases, but we need to spread this knowledge to rest of the medical faculty, to general public, and to psychiatrists too, because psychiatrists don't understand this yet. So standing there, yes, we need to do it. Apart from disorders, what are the some deviation or trait? This is what the interesting part is. You have pointed out the elephant in the room. If everything is genetic, then there is somewhere a so-called normalcy, somewhere there is so-called definite illness, and there is somewhere a broad line which contains some normalcy, some pathology, and we are still searching for that line. We can now say we have started to find some behavioral trait, right? Obsessive compulsive personality trait. It's a trait. There is no disease called OCD, but there is a personality, lifelong personality trait, which is obsessive compulsive personality trait, which can be divided due to multiple various brain processes. Anyway, I'm not going into those brain processes. But obsessive compulsive personality trait denotes a specific vulnerability profile which would manifest as either cerebral only symptom, means depression, means so-called severe obsession and OCD, means various bipolar symptom, various psychosis, and in later phase of life, various neurodegenerative disorder, Parkinsonism, or Alzheimer. And in body level areas, there would be more chance of diabetes, more chance of cancer, more chance of various other things. Some of the traits are called together attention deficit trait. They again have their own vulnerability profile in brain and rest of the body. So yes, these are vulnerability traits we have started understanding. Do we need to treat them if they develop functional deficit? Do we need to treat them? Yes, if they develop body-like well symptom, means the person has attention deficit trait and started developing metabolic syndrome, then we need to treat the brain, because these people's metabolic syndrome is systemic manifestation of brain vulnerability. So yes, we know some of the things that can be treated. We don't know a lot of things which cannot be or can be treated. But there
Dr.
is a broad line dividing normalcy and pathology. Yes.
Dr. Balbahar
And next
Jadeja,
question.
yeah, Dr. Balbahar C. Jadeja wishes to understand learning to cope with various perceived adverse events can help build up more resilience of the brain through various therapeutic interventions.
How would you train a brain which has a vulnerability to develop various resilience? If my brain has a vulnerability in calming my hippocampus, hypothalamus into going in whenever they are presented a situation which they don't like, how would you train my brain to not go into an aggression frenzy when they are exposed to something that is unavoidable for them and they cannot do flight, so they have to fight. So it is not possible to train them. We can give them medication if it is hard, and that would solve the issue for most. Or we can tell them that repeated exposure of those things throughout the life can bring about some tolerance, but not resilience. Then,
Dr. Dakshinamurthy wishes to understand if so, then is it possible to change traits of individual through drugs in future?
yes, and Dakshinamurti, okay. Not in future. We have already arrived there. Let me give you an idea of a small experiment. Take a person who is very obsessive, very perfectionist, very particular in everything, who wants to do a job truly and who has very rigid nature, and give the person some HSRI in some other context. Uh, Make the person understand that there is the GI disturbances that the person is experiencing, that, or make the person understand that the person having body pain is due to something, and start them on any SSRI which is suitable for you, for them. Let's say the person is not sleeping well, then escitalopram, paroxetine, and things like that. If the person is sleeping more, then fluoxetine and things like that. And then observe the person for 1 year. You would see the brain is changing. The brain traits are softening. The brain is loosening up. And you would see the brain is getting changed in presence of a drug.
Dr. Gautam Das would like to
Bio,
know. Sorry?
let I have seen the question.
Yeah.
Let me give you the understanding of typing. If a disease is being classified by its phenomenological expression, then the phenomenological expressions are biotype. Sorry, phenotype. If a group of disease is being classified by their pathological finding, then the disease would be called pathotype. If a group of disease is differentiated by their genetics, then it would be genotype. And if a group of disease is being classified by their biomarker finding, then it is biotype. So this is not a biotype. Biotype is classification of disease based on their biomarker signature. So biotype is something else. These are traits, lifelong genetic traits. There are various lifelong genetic traits that have been identified. In fact, the more we see, the more different genetic traits phenotypical genetic traits that we are identifying. We may call it behavioral endophenotype. We may call it something else, but exact name we can not be sure at this moment because there is no consensus on the names. Yes.
Okay.
Anything more?
I think there are no further queries. I take this opportunity to thank Dr. Bhaskar, Dr. Malay to help me put forth this. I also thank all the participants for having joined us to make it successful. I also thank Alchem Neuroscience for helping facilitate this program. Thank you, everyone. Good night. The recordings will be done and it will be uploaded. The link will be passed on to you. We are expecting your feedbacks eagerly. So do not hesitate to give your feedbacks, be it constructive or otherwise. Thank you and good night to all.
Doesn't matter. Just give your opinion.
Yeah.
Whatever you want, you can say it.
True. Okay.
Okay. Good night.
We leave the meeting now. Thank you all.
Good night.